Welcome everyone. We're going to have an exciting 2 hours, and hopefully we can get you through two interesting cases of conduction system pacing. The two cases being presented from Sri Raj Hospital, and we have Krit Jongnarangsin and Sachana, Dr. Q, moderating from the hospital, and Dr. Sharma from Rush University is operating in one of the rooms, and Dr. Waijian Wang from Wenzhou, China is going to be doing the other case. And so I have my partner here, Dr. Wes Mohammed from Australia. So depending on how the case flows, we may have opportunity to ask questions. Any suggestions from the audience will be welcome. We can ask you along. And we'll also have, we'll try to be as less interruptive as possible. I'm going to start off today with a couple of introductory slides and a short presentation, and then we'll get started. Again, good morning, everyone. These are my disclosures. So why perform His-Purkinje conduction system pacing? We all understand that this is the most physiological form of pacing, as we are able to pursue conduction through the native His-Purkinje system. And the chance for developing pacing-induced dyssynchrony and pacing-induced cardiomyopathy is minimal with His-Purkinje system pacing. And we can achieve both atrioventricular and interventricular dyssynchrony at the same time. And we have, because of all of these factors, significant clinical advantage over traditional RV pacing, and in my opinion, even much more advantage over biventricular pacing. So the important thing about the anatomy is that you have to appreciate where the His-Purkinje conduction system is, and you have both the atrial and ventricular aspect of the membranous septum where you have access to the His bundle. So you can be in the atrial side, I don't know if the pointer works, where it mentioned A, so that part you're still on the right atrial side where the proximal His bundle lies, and the distal His bundle as it traverses the tricuspid valve area and reaches the ventricular aspect of the membranous septum. So both sides are available for His bundle pacing. This is a autopsy suggestion showing, I wanted to show this basically to show that if you look at the section, the tricuspid valve is way below, but you can see the ventricular myocardium above the tricuspid valve. So you can still be above the tricuspid valve and achieve capture of the atrial tissue, His-Purkinje conduction system, and the ventricular myocardium. And just to go over a few basic concepts of His bundle pacing, so you have selective His bundle pacing and there is non-selective His bundle pacing. Most important thing is you have His bundle capture in both situations. So here in selective His bundle pacing, you have a narrow complex QRS with a HV interval of 40 milliseconds. And when you stimulate the His bundle and you have that isoelectric line, which is the time it takes for conduction from the His to the ventricular onset, and in the local electrogram, you will see that there is a discrete ventricular component. That ventricular myocardium is not captured by the pacing artifact. So that should be discrete. That is the primary example of selective His bundle capture. You're capturing only the conduction system and not capturing any of the ventricular myocardium. And in the other hand, when you have non-selective His bundle pacing, you have in this example, at a slightly higher output, you have capture of both the His and the underlying ventricular myocardium. And when you go down on the output, you lose the His bundle capture and you have only ventricular capture. So it's essential that you call the 1.2 volts as the His bundle capture threshold, not the RV myocardial capture threshold. So in non-selective His bundle pacing, there would be a transition from non-selective capture of both to one of the systems, either it's a myocardium or it will be the His bundle alone, as in this case, where at a higher output you have capture of the both tissue and at lower output you lose the RV myocardial capture. And here the His threshold continues to be below 1 volt, so it's important to pay attention to those things. So those are the important factors with selective and non-selective. There's a lot of nuances when you have underlying bundle branch block. You have further distinction of whether you have capturing the His bundle with or without correction, and then whether there is myocardial capture. So I would suggest you look up one of those articles that explains them in great detail. So currently the available tools are you have a Medtronic. This was the older deflectable sheath, and a 3830 pacing lead which is delivered through the sheath so you can precisely get to the His bundle region. However, the most commonly used sheath is the C315 His, which has a preformed curve, both the proximal curve that gets you to the tricuspid valve, and then there is a septal curve that allows you to fix the lead perpendicularly to the septum. And recently there's been a deflectable, the one in the middle is a deflectable C304 His sheath, which has the ability to deflect and have the septal curve so that the fixation is a lot easier. Early in our experience, and many other implanters would use a mapping catheter, and I would suggest for a beginner, maybe you can start placing a mapping electrophysiology catheter to locate the His bundle and then take your lead and the sheath to the site to fix. But as we evolve, we've just started using only the lead alone to use unipolar mapping of the His signal through the sheath and the lead, and you can achieve good electrograms through the electrode and either pacing system analyzer, or we can now use most of the recording systems and use that to demonstrate your electrograms. So I just want to show a quick example. This was a patient with atrial fibrillation, and you can see that in this example, the sheath is right near the mitral valve, but the lead is still within the sheath. Because of the septal curve of the C3115, it's attached to the wall, and so the blood acts like a good conductor, and sometimes you can record electrogram His potential right from when the lead is inside the sheath. And all I have to do is advance the lead to the tip, expose it outside the sheath, and you can find better His electrogram. And I'll passively rotate the lead and fix at that location, and you have His bundle injury current there. And pacing at this site, we can get selective capture. So that's commonly done. More than 50% of the patients, you can get, the sheath will get you to the His location, and fixation is similar to any other active fixation lead by passive rotation of the lead. And I just show you a few connectors. One way to do is get your input from the patient with a cable and plug it into the recording system, and you can take the signals from the recording system both to the PSA and to your monitoring station. So, and you can demonstrate beautiful electrograms. And as you can see, before fixation, you have the signals. And after fixation, if you adjust the filter settings, you can demonstrate injury current in the His bundle itself. So those are important factors to assess how good the threshold is going to be acutely, whether it'll get better following fixation. When you have injury current, it gets to improve afterwards. And so in some of the other possibilities, early implanters can also try to use a 3D mapping system, whether it's a Cardo mapping system, or you can even use one of the Insight precision mapping system. The advantage of precision mapping system is that you can use unipolar. You don't have to display both electrodes. And since we predominantly use the sheath to find the His, and we just have the tip outside, the Insight system works better than the Cardo system, where you have to display both electrodes have to be outside the sheath. And once you have the use an electrophysiology catheter to map the His bundle region, you can document whether there is areas with bundle branch block correction, and then all you have to do is take the lead straight to the location where you want to fix, and that would make it a lot easier, less fluoroscopy time, and that's what we were able to demonstrate when you compare with patients who we did conventional way. The amount of fluoroscopy was significantly less. Of course, this may not be cost effective, but in early cases when you do AV node ablation, or in the beginning difficult cases, this would be a good way to start. And just to quickly demonstrate what I mean by injury current, so you can see not only you have myocardial injury current, you see the His bundle and then the ST elevation following the His bundle signal. It's critical sometimes the His signal, which is a very sharp signal, gets blunted and becomes low amplitude. But if you display the filtered electrogram, you will see the injury current. And the injury current acutely may give you high pacing threshold, which invariably will come down significantly low, and you will have good threshold by the end of the case and often even the next day. When we looked at it, this was a retrospective series. We were able to demonstrate injury current in about 40% of the patients. But currently, with a deflectable sheath, we can demonstrate injury current in more than 70% of the patients. And when you have injury current, those patients tend to have much better threshold, both acutely and in the long term. Because of what we have today, I'm just going to quickly discuss how do we map in the setting of complete AV block. Here's a patient with complete AV block. You have right bundle branch block escape rhythm. When we see that, even though the QRS looks relatively narrow, this is very likely to be an intra-Hisian AV block. And so we map with the lead, and here you have larger atrial electrogram and the His signal with injury current. But however, this is a fairly proximal site. Pacing at this site was able to correct and conduct through the His bundle, but at higher threshold. So you have to map a little bit distal, anticipate the course of the His bundle, and if you go a little further, you can demonstrate a little bit of far field electrogram, or even otherwise just pace map at that location, and you may find better signals. And this is what we found. We're able to find a very low threshold to completely correct the underlying conduction system. In the fluoroscopic view, you can see the first site is a little cartoonish example, and if we assume, my assumption is that most of the time this conduction block is fairly discrete. And if you move around a little bit, and you can get to a slightly distal site, and you will be able to get a better capture threshold. Sometimes the His bundle penetrates deep very early, and you may not be able to get good capture threshold. And thankfully, we have the second half of this session, Dr. Wong will be demonstrating the left bundle branch pacing, which circumvents some of the need for finding a distal His site. You can get to the left bundle region itself. So what are the challenges with this bundle pacing? Depending on the operator experience, the success ranges from 70 to 92%. In our experience, the 92% in a large series of 330 patients. Every newcomer who needs a pacemaker, whether it's infranodal, AV nodal block, sinus node dysfunction. But often you find that the fixation is the challenge in about 10% of cases. You may have to modify your tools a little bit. His is a very precise target, and it requires fine manipulation of the sheath and the lead, and often you may have lower success in patients with infranodal or HV block. And 10% of patients have higher pacing thresholds at implant, so you have to decide whether it's something acceptable or not. And what is bothersome to me at this point is that about 10% of patients, even if they have good thresholds acutely, there is some progressive increase in thresholds. Well, the 90% of patients behave well. I have still not been able to decide which of those patients are going to have increase in threshold. Very close follow-up is necessary in those patients. And of course, because of that, there's a higher incidence of lead revision compared to traditional RV pacing. And then equally, there are sensing challenges. At the His being at the AV annulus, there's lower R waves and maybe sometimes bigger P waves, so you have to work around how best to place the lead in a better location. And atrial oversensing, ventricular undersensing, and occasionally atrial capture can fool you as a His bundle capture. So recently, Dr. Wong and others have developed this method to get the lead deeper into the distal conduction system. And in the left bundle area, we are able to achieve very low and stable pacing threshold, larger R waves, no issue of oversensing of the atrial signals. And in addition to left bundle branch capture, you also have the luxury of left septal capture, which may be equally good in many patients. The idea that the left bundle region may be easier than His bundle, because if you think of the His bundle as a very narrow tract and the left bundle branches out in a very wider spectrum, so larger target area to reach. And these are some of the slides borrowed from Dr. Shivkumar. You can see that There is significant variation in the distribution of the left-sided conduction system. This particular patient has a very wide left bundle, then arborizes extensively. So you don't have to be in the very proximal segment. You can be even a little bit distally and still be able to get into the conduction system. And here are some of the examples where this conduction system is somewhat sparse. You may not get into the potentials that easily. And then there may be other patients like this. You may have huge left bundle branch potential that you can very easily achieve. And so to complete, just to have an understanding of what the course of the anatomy is, where does the right bundle lies, where the left bundle is going to be, looking at it from the RV perspective, it's important to know. And this is just a quick show of how you locate the His location and then move the second lead slightly distally. In RAO projection, rapid rotation of the lead to try to penetrate the septum. And once you're across, you can see that you can assess how far, how deep the lead has passed into. And there are several methods to look into it. And I'll just quickly go through the steps so when Dr. Wong performs this case, it'll be easier to understand. Get your usual venous access. Then locate the distal His bundle. In the beginning, I found it easier to leave a lead in the His bundle and then bring a second lead to access the left bundle region. But you don't have to do that. You can mark it fluoroscopically and then move your catheter about 1 centimeter to 1.5 centimeters towards the RV apex in the direction, which will be slightly inferior to the His location. And then pace map that region. Try to identify an area where the pace QRS morphology looks like a W pattern. May not always be necessary, but it's very helpful. And once you find that spot, partially fix the lead, screw into the septum, and then bring your sheath all the way near the tip of the lead and orient the sheath in such a way that it's perpendicular to the septum. You have to use a right anterior oblique view and LAO view to confirm those things. And then as you fix the lead, advance the lead, you can check what's the shape of the QRS in lead V1. Does the morphology change? The notch in the bottom of the QRS complex in V1 should move towards the right of the QRS complex towards the end. And once you continuously follow pacing impedance in these patients, and you will see a gentle rise in the pacing impedance. And when it starts going down, then at that point you need to rotate the lead fairly slowly so that you don't perforate into the septum. And watching for changes in the QRS morphology, watching for potential, and looking at the impedance, all three parts of it is important. And if you have somebody with left bundle branch block, it's important that you have a backup pacing lead so you don't get into complete heart block during the manipulation. So this is what I mean by, if you look at lead V1, there's that little notch in W pattern. Sometimes you can pace at a high output to see if you have capture there. And if does it show any narrowing of the QRS, that may suggest distal capture of the conduction system. But as you advance the lead also, try pacing at a high and low output. If there is a significant variation in morphology, that might suggest that you're getting closer to the conduction system. So here in this fluoroscopic image, you can see how you access the distal His location, point the line towards the apex, and in that line is where your left bundle is going to be about 1.5 centimeters apart. And as you advance the lead, you can see progressive changes in the V1 morphology. And as you develop the right bundle branch morphology, that's when you slow down and you see the impedance changes accordingly and also find the potential. And during this time, you can also assess the time to peak activation of the LV by looking at the R waves in V5, V6. And that will move in as you get closer to the LV septum. That will be a good indicator for us. And you can also watch for the change in potentials as you get closer and closer to the LV septal surface. And the high and low output, early in this implantation, you can see as you're penetrating partially into the septum, at a higher output, you have a shorter peak activation time. At a lower output, it's longer, suggesting that you need to go a little further into the septum. And as you get into the septum, it doesn't matter high or low output, you're capturing the conduction system. So the peak LV activation time is significantly shortened and remains equal whether it's high or low output. And here's an example of a patient with left bundle branch block. His bundle pacing corrects it, but at a high threshold, and then mapping to get into the left side. When you have a narrow complex escape rhythm or a PVC that originate from the site, you may see the potential in the setting of left bundle branch block. Just want to quickly show this before we get to the end, live cases. So one of the things is we do all of the pacing during left bundle branch implantation with unipolar mapping. So you have here at a higher and a lower output, you see the change in morphology of the QRS, suggesting it's a non-selective left bundle and LV septal capture to move to selective capture. And when you do bipolar pacing, because the anode RV ring is in very close proximity to the RV septum, you will have changes in morphology. As you can see, the right bundle branch pattern is somewhat offset because of early pre-excitation of RV septum from anodal capture. And you go down on the output, you lose the anodal capture. So it's important to watch for that. If the threshold for that is less than 3 volts, easy to utilize it to correct the QRS morphology. If it's too high, it may not be that important. And the orientation of the lead and the sheath. In RAO, we want the lead and the sheath pointing at 12 to 1 o'clock angle. That would suggest you're perpendicular to the septum. It may vary a little bit depending on the anatomy of the heart. And in LAO view, it should be between 2 and 3 o'clock. That would give you the most shortest route to the LV septum. Thank you. And I'm just going to quickly present the cases. Are we ready to connect? All right. Let's go live. And can we play the slides once? All right. Can we go back to, so I can present the case that's being presented? Can we go earlier? Let's see. Okay. So one of the cases is going to be an 80-year-old male who has a prior history of inferior wall MI. LV ejection fraction is normal. A small inferior wall scar. Septal thickness is about 10 millimeters. Presents with complete heart block, as you can see in this EKG. But we're concerned that this patient has a right bundle branch block pattern. So there's a high possibility that this is going to be a HV block, infranodal intrahisian type of block. And the second case is going to be a 79-year-old male with prior coronary disease and presents with 2-to-1 AV block with a heart rate in the 40s. EF is again normal. We'll find out what the septal thickness is. I think Dr. Wong is going to do a left bundle branch pacing in this case. So it's important to know what the echocardiographic septal thickness on an average is so that you're not surprised by a very thick septum. And this is the EKG with the narrow complex with high degree AV block, more than 2-to-1 AV block in this situation. Let's go live, please. Hello.
Hello.
Good morning.
Can you hear us okay, Dr. Krit?
Very good. So can you introduce yourself to the audience, and then you can tell us which room you're in and who's operating?
With Professor Sharma from University and Professor Krit Jongnarangsin from University of Michigan. So right now we have prepared the patient and then put some dressing in, and we are ready to go on the live.
All right.
Okay. Thank you for having us. So this is turning out to be a very interesting case. I don't know if this is as ideal for his funnel pacing, but I want to bring your attention to some of the things we've already done. We got started a little while ago. So as you can see on the baseline ECG, the patient has complete AV block with a right bundle branch escape rhythm. It looks like a junctional escape with a right bundle branch block, QRS width of 190 milliseconds. It's a very typical looking right bundle line pattern. There's a slow S wave in the lateral leads and a RSR prime in the lead V1. Let's go to the left bundle escape, please. So as we started the case, the patient then switches to a left bundle branch escape rhythm with a QRS width of about 170 milliseconds. And you can see here, this is not the most typical looking left-hand branch, so there's also some slurring lateral leads here. So all of these findings are very concerning to us for high-grade block, distal his block, or one branch block, true anatomical one branch block. So we started off here, as you can see on the fluoro images, we started off with putting actually a backup lead. The backup lead is actually a 30 and 30. The reason for that was in case we need to move over to left on the branch casing, then we already have a lead at the his bundle, we can use the second lead to do left on branch casing. So that was our backup. And we started mapping the his here, so let's show the slide with the infrared block. So as you guys can all see, let's gain up the filter by one. As you can all see on the side on the fluoroscopy view right now, the distal lead is in the ventricle for backup pacing, and the proximal lead is close to the his bundle region, and those are the electrograms we recorded at that site. So you see A his followed by block, and that AH interval was about 110 milliseconds, and there's no HB association. So we have not found a distal his site, although this site seems fairly distal because the A is very small. But the idea here is now to get a little bit more superior and anterior on the conduction system. If you can imagine the his conduction system going to 80 node his and the right bundle, like Dr. DJ highlighted in one of those slides earlier. So we're going to try and get more superior and anterior. But in order to do that, you can see already based on the photo image that I'm already extending out my lead quite a bit to get up to where the his is. So in order to go more superior and anterior, I probably have to reshape the sheet. So I stopped here just to show you how we're going to do that.
Parikh?
Yes, sir.
So could you show us if, are you able to pace from the site to see if there's...
There's spacing at that site. So you can see there's capture of the myocardium, but there is AH dissociation, so the proximal his is dissociated. This could, we didn't see a significant change in morphology or change in outputs at this site, so we're just going to map a little bit more before we start accepting sites or liking something.
So there appears to be partial capture of the His-Purkinje system if you look at lead 2, the rapid activation pattern. So I'm not...
So we were suspicious of this being non-selective, but we didn't see a change in morphology and the pacing and different outputs. So what I want to do is maybe map a little bit more superior, and if we find that this is his potential, I might feel more confident.
All right, go ahead.
So
While you're doing the shaping, just show us how you do it. And
so as you can see here, we have the sheet back out of the body. So this is the natural curve of the sheet with the curve towards the artery and the curve towards the septum. What I'm going to
feel
do is
free
more
to
make
ask
more
questions.
superior. I'm going to curve the proximal end of the sheet.
Welcome.
So you get
Dr.
a little bit
Arisara?
more superior.
Nice to meet you.
Hopefully that'll help us
Yeah,
out.
feel free to interrupt, ask questions as needed. For
Just like we curve a K-shaped stylet. A little bit of curve at the septal side for points more anterior. So now you see instead of being down here, this is a little bit higher. So hopefully that goes a little bit higher than in the end.
May I make a comment, Parikh?
Yes.
So hopefully with the new C304 his sheath, we don't have to make these adjustments because the deflectable sheath allows us to get up to the superior aspect a lot more easier. So
Yes. Absolutely. That's a very good point. I think it's very important with this particular sheet, just given the caliber of it, if you just try to reshape it without the dilator in it, the sheet tends to get kinked easily, and so that's why we like to do it with the dilator in it. So we're advancing back, as you can see on the floor image, we're advancing back into the ventricle. I usually try to advance my sheet all the way to the ventricle before I start mapping. So there the sheet is, the lead is, the wires in the ventricle, we can advance the sheet all the way in, and then take our lead and go back in. Some leads.
The morphology of the PVCs you are inducing or attempting for left bundle pacing.
I already have the second lead at the side for the morphology set for left bundle branch pacing. So the proximal side not able to get up that much higher with this. There's that same side with a little bit of a hiss after the A. Not as consistent because I don't have reach. That's the proximal or the hiss with infrared is lost. We can let me make it a little bit more consistent so we can taste and show the audience what our morphology is.
Yes, so one of the things in infraneural block is to attempt pace mapping because if you may not see the distal hiss because the escape rhythm is way lower.
So you see there's a difference in morphology between some of these trees, which generally implies no adequate contact with me. So I'm going to try and make it a little bit hoping that there's still a dissociation of the proximal A and H from this side of pacing. That's 5 volts. Let's come down to 2 volts. Go back to 3 volts.
Now there's a change there.
There's a subtle change there. So let's go to 10 volts just to make it more dramatic. And now let's go to 3 volts. Very subtle change, Dr. Vijay, so I wasn't as convinced. It's a little bit wider, but not as impressive.
You're right, it's not capturing the entire hiss bundle, so partial fascicular capture.
You can slowly come down to 30 and go off, please. So you see, I'm having to reach with the lead because of the lack of support from the catheter. Now the other challenge might also be with this escape rhythm being more ventricular, you might not see a hiss preceding the QRS. And so we're going to have to do a lot of pace mapping as Dr. Vijay highlighted.
Because as you said, the escape rhythm is a left bundle branch block pattern, so it's escaping from probably right bundle branch region, so you may not find a potential.
Very low. Let's pace here. I think this might be a site where pace at 5 at 1 piece, at 40. So this is a site where left on branch pacing might be good with that W pattern like Dr. Vijay was showing you earlier on VV1.
How big is your R wave at that site?
Earlier when we checked that the distal lead, the R wave was 12, so go off pacing slowly and give us an R wave sensing interface.
The reason I was asking is that sometimes the R wave gives you a sense of whether you're proximal in the membranous septum. If it's in the membranous septum, it's very hard to penetrate. So it's good to have.
Pure is about 8.5, 8.6.
Yeah, that's pretty good. Because if it's less than 5, sometimes I find that it's hard to penetrate the septum in that region.
We're trying to get a little bit higher somewhat if I can. If not, I'll try to reshape it one more time and then switch to the MPR sheet and sheet option. Let's try pacing surface. Not stable, but at least let's see if we can get it.
We can try pacing there.
Yeah, let's pace there. Right? Okay, go to 10 volts. That's 10 volts. Now let's go to, okay, let's go to 3 volts. So there's a subtle change in V1 with notching, but it doesn't really result in a much wider QRS. So maybe we are capturing a little part of the Purkinje system, but it's not what I would like to accept.
Not ideal, yes.
So come off slowly. I'm going to reshape the sheet one more time. If not, we'll probably do a sheet by sheet and then finally up our branches.
So while you do that, do we move to the other room or is Krit around?
How things with Dr. Wong, sir?
Can we communicate to room 2? All right, so as we are shifting to room 2, Wes, do you have any suggestion?
I think at this point, especially given the level of block, it'd probably be a good idea to progress to deep septal pacing. It appears. I think the reach is an issue, which is a problem, and the level of block and how distal it appears to be, I would be inclined to go towards deep septal pacing at this point.
Sure. We'll see if Parikh is able to get to the distal His bundle. If not, left bundle will be the option. And can we go to room 2, please? All right, so Krit and Dr. Wong, we can hear you. Krit, can you hear us? So you're live, Dr. Wong and Krit.
Yeah.
Could you?
Morning, good morning, Togo and audience. And now we have a patient with TB block. The chaos compressed is never, but during the procedure we found the patient with intermittent right bundle block and left bundle branch block. Intermittent presents show the ECG. Yeah. RBB pattern. Yeah, RBB pattern and LBB pattern. Now, yes, real time. Real time, yes, is LBB pattern.
Yeah.
Now, we have finished his bundle pacing. And it's very clear there is his potential with current injury.
Could you demonstrate, show us the signals? Yes.
Yeah.
Okay, there you have.
Yeah. And the threshold is very low at 0.6 volts. And left bundle branch block can be tracked. Now, pacing his bundle. Okay. Yeah. Done. Decrease output at 1 point. Yes, we have selected his bundle pacing, but pace the morphology.
Right bundle branch block.
Yeah, right bundle branch block. So, decrease 0.9 patient with AV block and with intermittent left bundle branch block and right bundle branch block. So I will try left bundle pacing.
So, Krit or Dr. Wang, what was the HV interval during those periods of narrow complex and periods of right bundle, left bundle branch block?
Maybe with pacing rate, with heart rate.
So, what was the baseline HV interval?
About
40 milliseconds.
Yeah. Then the heart rate increased to 80, more than 80, then left bundle branch block pattern appeared.
So the important point here is that when you have AV block and when you're not sure of the site of block, it's important to assess that at the time of because if you have a narrow complex and it turns out to be an intra-Hessian block, and you accept the threshold because there's one-to-one conduction, but you wouldn't know unless you pace faster in the atrium or faster from the His bundle at 120, 140 beats per minute. You have to ensure that there is one-to-one distal His capture. Otherwise, we may come back with HV block and the lead being above the side of block. So that's important. And was the right bundle and left bundle branch block happened before you implanted the lead or during implantation?
During the procedure.
So while you're manipulating the lead.
Maybe. And now the impedance is 480, and the amplitude, the sensation is 5.
So can I make a comment there? So when you first mapped, the HV interval was normal, the QRS was narrow. So is it possible that when you implanted the lead, because you have such His bundle injury current there, you caused the acute intrahessian block, and that may not be his underlying problem? And this is very likely to resolve.
Yes, but we place the lead at the right atrial side. We haven't placed the lead, advanced the lead into right ventricle, just at the right atrial. So maybe the lesion, or we know the lesion at his bundle can cause distal block pattern. For example, place lead, we place lead at his bundle area and cause right bundle block or left bundle block, like longitudinal association.
Yes, that's been well described, that when you have even a normal His-Purkinje system, as you implant the lead, you can cause acute injury. You can create left bundle branch block from the atrial side itself or right bundle branch block. And invariably, that will be associated with significant injury current on the His electrogram. Is it possible for you to show us the filtered or unfiltered electrogram on the His signal? So
It's not amazing. With the filter and unfiltered to see his potential and current injury. 改变一下它的力度。With different filter.
yeah, so on the His electrogram,
Yeah, will give us typical
so what we
current injury.
So what we do is change the high-pass filter from normal of 30 hertz to move it down to 0.5, and then you will be able to see that. Even if you look at the His electrogram here, it's not a very sharp. It's a wider electrogram, and that would usually suggest there's significant injury current on the His bundle.
Pugel? Pugel?
Yes.
I was just going to say, I don't know if they can get back to it, but it would probably be interesting for everyone to see what the His signal looked like originally before the injury, because often once you've got
will be
injury,
help.
you might not be able to make it out.
The rhythm actually looks like an accelerated hiss rhythm with still AV dissociation. The other option for you is to show us the hiss electrogram before you fixed.
The video, could you? Into. The monitor showed. The monitor showed.
Yes.
Okay. The monitor showed. Current of injury. It's very clear.
Which one is it the ventricular electrogram?
The middle channel. The middle channel.
Middle channel?
Yeah.
Can you gain up on the atrial electrogram there?
Sorry.
It's the bottom.
The middle is left bundle.
Okay. Yeah, so we can see that on the ventricular electrogram. Can you gain it up one more notch? Yeah, so you can see the HV is a little bit prolonged, and there's injury current on the His electrogram.
The bottom left channel is his bundle.
Yes.
Okay. Now, we have a fund left bundle facing that for the initial turning and showed the pace morphology at the right side of the vegetable. It's clear W pattern.
So have you implanted the lead, or you're just beginning?
Beginning, I turn the lead maybe deeper, 7 millimeters deeper, then stop waiting for the curve.
Oh, so we wish you had shown us right from the beginning. All right. Show us the electrogram where you started before you implanted the lead.
The notch at the bottom. Okay.
Okay.
Okay. Then next.
You can see that the notch in V1 is moving more towards the right of the electrogram, so in the ascending limb, which is suggesting the lead is moved a little bit deeper. So this is the notch that...
Now please. Now the notch at the end of the cut with vertical acceleration. And the crest is narrow compared to before.
So Dr. Wang, can you explain as what fluoroscopic view that you are just displaying, the one that's playing right now on the fluoroscopy? Is it right anterior oblique 30 degrees? What do you prefer?
Yes.
And can you explain to the audience, how do you assess the lead and the sheath are perpendicular to the septum?
At right anterior read, it is clear to position because this is the longest view of right ventricle. We usually place the lead, LW place the lead
So what he's suggesting is that this is the tip of the His lead, and this is the point where he started. So if you draw the line towards the apex, so don't look at the tip of the electrode, it's already penetrated the septum. So it's from here to this angle. So this sheath is where he started penetrating the septum. So one of the important things to do is you advance the sheath close to the tip of the electrode. The sheath tends to point more towards the atrial side. So gently do a counterclock rotation on the sheath and then pull the sheath back so that the tip straightens up. So the tip is pointing this way, so you need to straighten the tip a little bit. So that's what makes it perpendicular to the septum, just like he has it pointing this way. So normally this would curve around this way, so we want to straighten it before you start fixing the lead. All right, so you want to continue to fix and show us what you're doing?
Yeah, we have engine operator.
Okay.
Play the video. Yeah. Now the lead is about 7 millimeters deep. So now please, now is excellent to set the pacing.
Could you tell us how you determine 7 millimeters?
Because we know right side of ventricle is at mid between distal tip and ring.
So the electrode, the screw itself is 1.8 millimeter. And from the screw tip to the tip of the ring electrode fluoroscopically is about 10.8 millimeters. So 9 millimeters from the end of the screw to the beginning of the ring electrode. So you have a total of 10.8 millimeters is where the whole distance is. So judging from the angiogram, it's somewhere in the middle of the distance between the ring and the tip. So he's assuming it's closer to 7.
Now the impedance is 730.
What was your starting impedance, Dr. Wong?
What starts the impedance is about 400.
400, okay. So one of the pointers to remember is that as you advance the lead, if the impedance goes up to, let's say, 1,000 ohms, and often it means the lead is taking a very longer path. It's not perpendicular to the septum, more transverse. So we don't like to see very high impedances. So I usually pull back and readjust, reorient the lead tip in that situation.
We can see, we decide to turn the lead further.
Okay?
And I think the deeper is better. Okay. We should know we use unipolar pacing, continuous pacing. Oh, too far. Sorry. Okay. How much is the impedance? Okay. And 5. Okay. 10. Okay. Now, are we right about the right pattern of in the V1?
So you can see the little R wave show up. So how many turns did you rotate just now?
Just 3.
3 turns.
3 times.
Okay. And can you measure the stim to peak at high and low output for us?
Measure the stimulation LVT. Then 92. Increase to 10. Increase output to 10. Then sharpening.
And you have much bigger. So that's very helpful, suggesting that he's near the left bundle branch region. At a lower output, the R wave amplitude is smaller. At higher output, the right bundle branch block pattern becomes more prominent, suggesting he is capturing the left bundle branch there. So you should have a shorter stim to peak at that point.
How much? 97. 87.
Okay, so there was one measurement, 72.
Yeah.
So you still have more.
At the 10, facing at the 10. Facing at the 10. No. Facing at the 10. Oh, okay. Increase output. Make it stimulation LVT time. LVT from 87 to 72.
Okay.
It's very clear. So apparatus shuttling is very important.
So do you.
At the same levels, but we increase output from central LV central facing to bundle capture. It's very clear.
We don't have a bundle potential yet. Is that correct?
But left brain this potential cannot be used because the patient has AV drop.
Okay. But you have a.
Now I will pace his bundle spacing. Pacing to see whether the potential is level of the potential. Okay. She got this. Done.
So even in the escape rhythm, there is a potential. Now we can see the potential on the left bundle.
It's clear. There is potential.
Yes. Can you go off pacing, because I thought we saw potential even in the escape rhythm. There is a potential. So can you gain up a little more? What is the gains on the left bundle electrogram? Yes, thank you. That's much better. So we can see the left bundle potential. It looks like there may be injury current on the left bundle potential also.
Yes, because now AV block happened again, and we slow heart rate, so the pulse duration is relatively narrow.
Yeah, it still looks like it's a AV nodal block with junctional rhythm, which is accelerated.
Now we decided to screw it further. Now, check that the impedance
Okay?
Now we measure the threshold for left bundle capture. So 5 intermittent left bundle capture. Now pacing at 5 output. Left bundle capture is intermittent. So this is okay. Now we turn it.
So, Dr. Wang, why do you say there is intermittent capture?
Now let's look at the pace morphology and stimulation to LVAT. If left bundle capture with narrow stimulation to LVAT and typical right bundle branch block pattern.
Okay.
Okay, now let's look at three. First beat is left bundle catch with narrow
This one is.
with narrow stimulation LVT, but with wide just complex. With wide just complex because right ventricular activation is much delayed compared to left ventricular activation because the left ventricular is controlled by left bundle branch. And the second just left ventricular sector pacing.
Okay, so what are you going to do now? You're going to do another turn?
Deeper.
Okay, let's see what you're doing.
Okay. Pacing at 3. Pacing at 3. Pacing at 3. Okay. 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 Now, at 3, left bundle capture with narrow at stimulation LV is very clear. Done. 2 and 2. And 2 and 2. Decrease. 1. 1. Now 2, 2.
Okay, so the
3, 3. The impedance, how much the impedance? 600, okay. Screen a little further.
So, Dr. Wang, because we saw injury current on the left bundle, it's possible that the threshold is acutely high. You may want to wait it out.
Done. 2. 2 is okay. 1. 1.5.
So he's watching the changes in the QRS morphology, V1.
How much the impedance? Okay, a little.
Are you going to turn more?
A little. Half better. Yeah. Okay. How much selective now will be?
Yep,
Now how much?
that's selective left bundle capture.
How much is the bottom?
What's your pacing output now?
Yeah. How to use 2. 1.5.
Selective.
How much is the impedance? 630.
Okay.
Okay, now just wait
Yeah.
to see LV potential first. 好，我们看下来的。That potentially begun logic with current injury. Now, here's about the basic. Here's about the basic. And what? And what? Yeah. Speed at 200. Yeah. Yeah, it's clear. Gain more.
So what he's trying to show us is that in this case, even during the escape rhythm, there's his bundle potential and there's also left bundle potential. But let's say if this was a complete left bundle branch block, there wouldn't be any conduction down. And the way to show that left bundle potential is if you do his bundle capture and correct the left bundle branch block, and then you will see that the left bundle potential will be there on your pacing electrode. So that's basically what he was trying to show. One of the difficulty with that is that you have to achieve selective selective his bundle capture with correction. When you have non-selective capture, the septal fusion sometimes masks the small left bundle potential. So if you can get selective capture with correction, it's very easy to demonstrate left bundle potential in someone with a left bundle branch block. But this is a very nice example of how he got non-selective capture to selective left bundle capture. But acutely, the threshold can be high. One of the very difficult challenges during implant is how far can we go? Now, the threshold was around 1.5. That would suggest that have we penetrated into the LV septum? And when there's acute injury current both in the LV septal myocardium and even in the left bundle, the threshold can be high. The one way to differentiate is looking at the impedance. So if the impedance stays around 600, 700 and didn't drop down to 400, that means you're still intramyocardial. Then looking at the quality of the electrogram, the ventricular electrogram in the left bundle pacing lead, unipolar electrogram, should continue to show significant current of injury. If it loses the current of injury and if it gets a fractionated signal, then the lead is penetrated into the septum. Then you got to reposition. So you can't just pull back the lead. So that's why towards the end, when you get to the LV septal surface, you go slow, half a turn, one turn. So you don't want to do it too fast because you then penetrate into the LV septum. The tendency will be to pull it back until you get good numbers, but we have nothing to hold the lead on to. It's sitting in a tunnel. It'll usually dislodge. So you have to restart all over in a different site to get into the LV septum. So Dr. Wong, we're going to break and go back to the other room and come back and see what your thresholds are. Yes, you've demonstrated all of the findings that we would like to see in a left bundle branch pacing. When we come back, we want to do threshold testing, both unipolar and bipolar, to demonstrate anodal capture. So we're going to take a break and go to the other room and then come back, okay? All right, thank you. Can we move to the next room? Hi, Parik.
We've exhausted our options for his bundle pacing here, from what I can tell. So let's go to review. So pull up number 5, please, on the review for everyone.
5.
So this was interesting. As we were mapping, we found this one narrow beat. And we weren't sure if there was a little potential free, but we paced at this site and showed them pacing at this site. Go to number 6. Number 6, please. Yeah. So we actually implanted the lead at this side, and you can see there's a little bit of junctional activity because the heart rate at rest was only about 30, accelerated junctional type rhythm here, we only saw that one narrow beat. And there's a little potential right at the outset of the local lead. So we decided to fix the lead because it was unstable here and try to pace. So let's go to number 7 so we can show the pacing here. So you can see the first couple of beats have a subtle difference in morphology compared to the last couple of beats, especially in B1. But it's not convincing enough for me to feel like this is an ideal site for me to accept. The threshold for capture here was less than 2 volts, but then again, I'm not very happy. We actually did a sheet and sheet. Let's show the last floor image, please. So the reference is, yeah. So you see here, can you see the floor?
Not yet?
Can you show the floor?
Yes, we can see now.
So you can see it's a very small area of difference. We actually left you see there's a sheet and sheet. There's a 315 going through your multi-purpose right. We implanted that at the side of the proximal hiss or the hiss where we had HV block, just to keep that as a reference. And we mapped all around that region. We got a little bit superior, a little bit more distal. And that site where the second lead is, more distal lead, is where we had that junctional ectopy. So we decided to fix the lead there. And despite that, we're only seeing this morphology. So I think we've exhausted our options with looking all over. More superiorly, more inferiorly, so we're trying to map that entire region. Not being able to find a convincing enough distal hiss. Just given the escape being more distal, except for that one junctional beat. So I think we're going to move on to that part of branch interfacing in this case.
So Parikh, I think we agree with your assessment. Your distal hiss is probably not easily accessible from the right side here unless you put the lead quite deep. Since Dr. Wang has done his left bundle pacing, we didn't see the beginning of how he did it. So you're going to show us every step of the way now.
Looking forward to it.
All right.
Okay.
So in between, you can ask them to focus on how you hold the sheath, orient the sheath, in every little detail that you can share for a new implanter. Wes, you have any comment in the meantime while he's getting ready?
I think just with that previous case, I think it was important if you saw the hiss signal originally, it would have been a very sharp spike, and subsequently you saw that it was quite deformed. And it's unlikely that if you went back to that hiss bundle region, you'll see again a very sharp spike. So sometimes people spend a lot of time searching for that sharp spike again, but you may not see it. So I think that's important to bear in mind. And the second thing with Dr. Huang's case is, I think, when do you stop screwing in? I think that's the big question that everyone would be asking, because it seemed very subjective when you...
Can you hear Dr. Mohammed? If not, can you raise the volume? All right, you ready to show us something, Parikh?
Yeah, so if you focus on fluoroscopy and just a little bit, maybe even a half a centimeter distal to where the hiss was localized, and pacing here is the morphology in the live stream with the W pattern. The second notch is a little bit bigger, so I'm not sure. I want to go a little bit more distal here, so I might actually move a little bit more distal.
So before you move, can I ask you something? This is my theory that if your local ventricular electrogram is small, that would usually mean it's a membranous septum. So can you tell us what's your R wave there?
Sure, let's go down slowly, and I think the last we saw it was slowly, okay, there. I think it's 40 or 10.
It's 10?
6
6,
here,
okay.
in this location.
All right,
I was just a little bit superior and it was going 18 and a half.
okay.
But I didn't want to be as superior because if you assess, just like Dr. Wong taught us, if you draw a line between the distal hiss, as we see, that's the distal most hiss we could find, between that proximal lead to the apex of the heart, I'm clearly along that course. Whether I need to go a little bit more distal or not is the question. But I find a site where my sheet seems to be stable. So I'm going to probably try this and see how we do.
So we have a lot of time, so you can try.
So I usually start with trying to fix the the helix a little bit into tissue. So I'll give it about 2 or 3 rotations so I get a little bite into tissue first. So that's usually my first step. Can you focus on my hand movements here? So one of the other things is my fingers are hurting right now because I'm wearing gloves that are a size smaller than what I usually wear. Because you really want to feel the movement with the lead in this case. So I'm going to give it 2 or 3 rotations. 1, 2, 3. Can you pace again and measure an impedance? The starting impedance at this site was about 270.
That's pretty low. The lead might have been inside the sheath.
I have actually pushed it out, and this is surprising. Most of this area, the impedance is about the same.
Okay, that's pretty unusual to have low impedance. Maybe a cable issue.
How's the impedance now? Yeah, so it's about 265 to 267, and I pushed the lead out of the forum. Clearly making one.
Yep.
In fact, there's an ectopy.
I like the W on the ectopy.
Yeah, I know. Okay. So now I'm going to gently pull this sheet back a little bit so we straighten out the system as opposed to buckle it backwards.
So is this RAO 30?
This is RAO 17. Let's go a little bit more RAO, please. Go 30. Alright, so as you can see, I'm a little buckled with the sheet, so my idea would be to pull the sheet back so it points the lead towards the 1 o'clock position. That's a little bit better. If you guys have any comments as we go along, I'm happy to.
No, I'm just concerned you're too close whether your ability to penetrate there or not. But it's okay, it's worth a try. You can show, and if it doesn't work, you need to go distal.
Very close to the membrane acceptance, so there may be a challenge of going through, but we'll try if not to move more distal. So, I want to make sure there's no blood on my lead, so I have a good grip on it. And I usually hold closer with both hands. I have someone hold on to the torque on the sheet. Hold with both hands.
Can the cameraman show us what you're doing? It's hard to see your orientation of the sheath. So in a C315 his, the hub is always pointing at 6 o'clock in a natural position. So when he says counterclockwise, the hub will move towards 3 o'clock location. In different individuals, depending on the rotation of the heart, you may have to vary that, and it's a feel that you'll figure out as you can see that as he rotated the lead, the sheath pushed back quite a bit. So suggesting that the lead is not advancing forward, the lead is pushing back.
Very suggestive of the fact that the lead's not moving forward, it's just pushing the sheet back. We see this very commonly in the area of the wrist bundle. If the lead fixates, it will push the sheet back. So
That's a good sign for his bundle location, but not so good for left bundle.
let's pace here just to see what our impedance looks like and if there's any difference in our part. Still 271. So not very happy with this size. I think we're going to move a little bit more. Although the QRS is
Yeah, QRS morphology looks some distal his capture there.
it's just we've not been able to. Let's pace at 10 volts here. Okay, and then let's pace at 3 volts. So not a huge difference in morphology to suggest
Okay.
after a loss occurred. Okay, let's go off pacing slowly. Okay.
So one of the things that we commonly see at this point is that, he fixed the lead, did a few rotations, and now he's going to undo and dislodge the lead. But often tissue may get into the electrode, And you may have to make sure take it out and take out sometimes it's a very tough fibrous tissue. You have to take it out of the screw and go back again. Otherwise, that'll interfere with how to advance the lead. So, is there any tissue attached? Okay. That's all right. If there's nothing, that's okay.
I think one of the key things that I've heard a lot recently is, as people are trying to disengage the lead, it gets stuck. So one of the key things to remember is you don't want to, if you're given 6 or 7 or 8 turns, you don't want to give 7 counterclock rotations to take the lead out. You only need about 2 or 3 advance the sheet to the tip, and you should be able to free the lead out. If you overdo it, there's a risk of getting stuck into the fibrous region or into the tricuspid valve coding. You have to be mindful of it.
So one way to advance the sheath is gentle clockwise rotation. So the septal curve of the sheath moves away from the septum, then you can move it forward. One sometimes challenge is that the sheath will tend to pop up into the right bundle region. So if you have a left bundle branch block, you're likely to cause damage to the right bundle and cause complete heart block. So if you find it very challenging, then I usually use a wire to cross and go distal and then pull the sheath back. That's a nice morph.
Can you show them the review screen, please? Go back to that lead that I showed you. I stopped there. Can you guys see the review screen here?
Yes.
So there was a beat when we were not casing that there. There was a beat, we missed it. There was a beat that came. That's okay. We'll try to go back to it and find it. But impedance is still about 250 to 260 or something.
I'm concerned that there's a cable issue. One of the cables is,
Can we try switching into the other set of
yeah.
cables? Can we, can you switch cables and you want to go off basic first? This is a nice morphology with the second limb of the W being shorter, as we highlighted earlier. Just switch the cables between the backup and this. That's all you need. Yeah, I'll switch to mine. Okay, let's face now with this lead. No, you gotta switch to. Yeah, I think you're on the proximal lead. You gotta switch them right. I switched them on my end. Yeah. This looks like the proximal lead.
Yeah, that's the His electrogram there.
This electrogram. Go off basic, let's see sensing here. I still see a His electrogram. No, you're not facing the right lead. Switch to the lead. Switch to connector on the right. We're not connected to that. We'll just switch it on your end.
Break. I'm going to take a short break, go to the other room. We'll get situated here. And can we go to the other room, please, so we can look at unipolar, bipolar pacing? Hi, Dr. Wong. Hello. How, where are we now? Okay, so you want to give us bipolar, show us bipolar electrogram.
Okay. Bipolar.
Not pace.
Stop pacing. Stop pacing.
Okay, so we have the nice, so you can see that his potential, the injury current has come down. It's become more crisper now, the electrogram, and the HV interval is also a little bit shorter now compared to before. I think what we had, that bundle branch block implant, was all acutely induced by his bundle pacing, which is a good sign usually because you get excellent threshold, as he showed that it was less than 0.5. And now he's gone back to show us the left bundle electrogram. So you're going to give us pacing from high output to see if we have anodal capture on the left bundle? What output are we pacing now, Dr. Wong? So we can't hear you, Dr. Wong.
1.5. 1.3. 1 point. Now, the level bundle capture threshold is 1.3.
Okay.
1. Point 9. Point 9. Point 9. Point 6. Can you hear me?
Yes, yes.
1.8. 1.8. 1.6. Okay. Now, I think we will finish.
So I know you're pacing at a lower output to see. We don't see the selective capture anymore, but
Look, my current temperature is
lower, yeah, that happens. But can you give us high output pacing to see whether there is anodal capture? Or we can start at 5.
3 volts, 2 volts, 1.5. How much the impedance? The impedance 650. 650. Yes, okay. Now the impedance is 650.
Okay. This is unipolar or bipolar? What you? Okay. Can you show us bipolar pacing? So we want to see anodal capture.
At 5. At 5. Output at 5. At 5.
Is that 5 volts? How about 10?
10. Local by target temperature to minimize multiple branch loss.
Yeah. So that's 10. Can you go to 5?
5. Yeah.
there's a slight, very subtle change. So the threshold is high. So can you show us the LAO angiography?
Okay.
So that'll give us an idea how.
To play the video. I just done that.
Okay.
Much deeper than before.
Yes, can we freeze the frame with the contrast lining? Go forward a little bit. Okay, perfect. Come back. There, one step forward maybe. Okay, so that actually shows us the contrast is here. So often the fluoroscopic view of the ring electrode is much wider. So the distance to this point is almost like 18 millimeters. So this would be 10.8 here. So this is probably 12 millimeters into the septum. Do we know what the septal thickness was in this patient? Krit or Dr. Wong? So even though the ring electrode's in good contact with the septum, in this particular case, the anodal capture threshold is high. I've been surprised that even though the ring electrode may be deep in, sometimes you don't get good septal capture. And other times you can get very low septal capture threshold. So did you advance the lead a little more?
A little more, yeah. But that's okay. I think that we can accept the results.
Yes. And we still have injury current on the left bundle electrogram. Are you moving the his lead to the atrial side?
Yeah, I just moved his bundle, his lead to the distal. How much it is?
Could you tell us what you're doing, Dr. Wong, at this point?
Just to screen deeper to see. Patient is bundle, patient LV patient. Okay, cool.
Okay.
There is a potential, okay, very clear.
Yep.
Ah,
So what we're going to do is,
bottom channel. This is distal
this is the,
from distal.
yes, okay. Yeah, and we can see the his to left bundle interval is shortened now. What we're going to do is go to the other room. When we come back, we want to hear which lead you're going to retain. But if you can paste the atrium when we come back to show us where the level of block is, that will be helpful for us to understand. So let's go to the other room, please. Hi, Parik. Parik, you're on camera now. Can we connect us? We can't hear you. Do we have communication with room 2, room 1? Yes. Parik, can you hear us? We have issues? Are we able to connect? Should we go back to the other room? While you fix it. Are you able to hear us, Parik? We are not able to hear you. Well, why don't you keep working? So can we go back to room 1, room 2? Dr. Wang, we are back to you. Can they hear us? All right. We can hear you, Dr. Wang.
I can hear now we move possibly to right Asian sector.
Which lead? The his lead or the left bundle lead?
Easily.
His lead, okay. That's in the atrium? So where is the level of block? Looks like it was AV nodal.
How about the sensation? 1.6 and with injury current. And now measure threshold. have speed back, like rebounding. That means better fixation for right pacing, right agent pacing.
So, Dr. Wang, one of the issues that we have when we use the same lead and the sheath to the atrial position is when you slit, sometimes it interferes with the other lead. So, which sheath are you going to slit first? Which sheath are you going to remove?
Yes.
The V or A first?
This is a good question. I'm not sure. Maybe it doesn't matter. But I prefer remove the piece bundle facing distal sheath.
First?
First, yeah, then perform right action.
Okay. You want to go ahead, slit the sheaths? You ready to accept or?
Later.
Do we have communication with room 1 or have we fixed? Can you hear us, Parikh?
Can you hear me?
Yes.
Okay, good. So we tried a few sites that were proximal, even distal to that first position we tried, and unfortunately our impedances are all consistently low all throughout this area. We changed cables, and a couple of times when we tried to screw it in, we got recoil. So it's, and there was some spot at the tip of the lead. So it's either there's spotting there, or it was that we were very close to the memory receptor. Although our always were about 9.
Okay. Let me make a comment there. So we wanted to have Dr. Wang do this patient first because he felt that the patient had previous infarct and that part of the septum would be scarred and will have difficulty doing leap septal pacing. So he wanted to demonstrate in the other patient. So that's exactly what Parikh is experiencing now. Maybe there is septal scar here. Sometimes you can go distal and get it, Parikh.
Yeah, so now if you look at the fluoroscopic view, we are a little bit further distal. Our sensing here is about 13. Although the impedance at pacing is still about 260, 270. Can we show them the pace QRS here on the reduced ranges?
Was the impedance in the HIS lead originally also was low?
Yeah.
Okay, so I think there is some issue in the connection somewhere.
We've
On the,
switched our cables, we've switched to different set of cables.
are you,
This is the pace morphology and the reduced screen in this region.
okay. That looks good. Are you having any of the pacing channels open on the recording system? Sometimes that leads to low impedance and confusion. If anybody has a pacing channel open on the recording system.
Do you think it's your connection with the adapter here, K1?
We have 15 minutes, Parikh.
Okay, bring your cable, connect your cable directly to the PSA and give me an impedance. Quickly. Okay, pace.
Yeah, see, that's much better.
How much?
600.
688. Okay, so it was your cables. Your adapter cable. So it's fine. We're not going to switch anything out right now. Do it directly through your PSA while we're screwing in. Make a note starting impedance of 680. Okay, can you zoom in on the junctions? So basically going to hold, release the two hands. She's moving. And I usually put one hand very close to the hub, the second one spins the lead. And it's a very rapid rotation, and I'm on floor here. So there's going to be rapid 4 or 5 rotations to see if we can get through here.
There's still a lot of rebound, it looks like.
That's pacer.
It's moved in a little bit.
Yeah, so you can see that the QRS, the W is a little bit wider, the notch is a little bit more shorter, and the impedance has gone up to how much? 710.
Okay.
So just a little bit.
Yep. Few more millimeters.
So I'm going to advance my CS sheet over it to maybe give it a little bit more support because I feel like the sheet is not supporting me as well against the sucker. And then we'll see if we can get it a little bit deeper. So that was about 3 more turns.
So I find that I'm not able to get a good idea how the orientation in the RAO is, Parikh. So in between, if you want to check in LAO, that may give you a better sense.
Sure, let's do that. So impedance is still about the same. The QRS looks a little bit different. Let's come out here. You can see the CS sheet might actually be working against me.
Yep.
Unfortunately, let me see if I can torque it up. Because it's slit, it's difficult to torque.
Okay. So we can see that in this view, the lead is pointing down. You're removing it now? The lead pulled back.
Yeah, I did see it pull back. I was just trying to orient it a little bit better.
Okay. So in this view, we would like between 3 o'clock and 2 o'clock. So if you go down, that's going against you.
Okay, let's face here again. Okay, face. I'm going to try and see if I can screw this in.
Sure.
LAO,
Okay.
just so we have that. Show me a little bit more from the table.
It pushed the sheet back. So we're going to go one last time back to the other room. We'll come back to you, Parikh. Looks like it went in a little bit this time. Okay, so did we slit the sheath? Dr. Wong? I think he's done. All done? So you slit the sheath. No issues removing the sheath? All right. So one of the challenges that I've had is that if I remove the ventricular lead sheath first, and when you remove the C315 His from the atrium, because sometimes it rotates around and it can pull the ventricular lead up. So for that reason, I would remove the atrial sheath first and then remove the ventricular sheath later. Anything to report, Dr. Wong?
Now we have removed removing sheets. And that's all.
Okay.
This is Dr. Chen, and this is Dr. Sun, my colleague. And today we show technology facing and selected is macro facing and potential determined injury. And we have very important sign for that value capture, shortening, stimulation to L8.
Yes. Thank you very much. I think you have a wonderful team and you performed splendidly and you demonstrated all of the features. Let's give them a big hand. Thank you. Let's go back to room 1, see if we can.
Update again.
Hi, Parik.
Measure this. Keep going. Okay, 87.
All right, he seems to have gone deep in now. Let's see.
That was right when you guys left.
It's okay. We wanted to give you the good luck charm by moving away.
So just as
Yeah,
you guys
there you are.
we saw the lead move forward a little
Yeah.
bit. The impedance was about 850. You can see there's a horizontal prime pattern V1 and there's a positive QRSs V3 to V6. The time to peak here, can you show them the review screen? Can you see a review screen? So on the review screen, you can see that the time to peak in V5, V6 is about 87 milliseconds. This is at 1 volt, and it is about 77 milliseconds. Can you click that one? So that's about 77 to 79 milliseconds at 5 volts and 10 volts.
So maybe another millimeter or two to go in.
I'm going to give it about a half an hour and see what happens, not more than that.
Yeah, we'll watch you. And we have a saying in our lab, pressure makes diamonds. I think,
That would be around call me a diamond, I'll take that.
all right, you got it.
Okay, so that's about a half to a turn more. Let's face again. Impedance.
Yeah, it has more of a right bundle pattern now.
Okay, so impedance went up to about 850, 860, and is now down to 760.
And the stim to peak looks very good right now.
Yep, so let's face at 10 volts. Can someone update for me and measure the stim to peak, please? Good, it's about V4, V5, about 85 to 90 milliseconds. Okay, face at 5 volts. Update and measure it again, please. I'm not sure where to measure. Go back to 10. Update again. Measure that. That's interesting. Not sure. No, I don't think you'll update now. I think you measured the earlier week. You see the third and fourth week was shorter. Yeah. Measure now. Go back. Yeah. So 70 milliseconds at 10.
Yeah, you can change the sweep speed too because it makes minor error on measurements there. Okay.
Total, what's the sweep speed right now? Is it 100? What are 150 in the sweep speed, please? Yeah, it's so 10 is 70, 75 milliseconds, 5 is 75 milliseconds.
Okay, let's do threshold down to.
Okay, give me 1 volt real quick, please. Lost. Okay, go back up, please. Okay, now let's come down slowly and give us a threshold, starting at 5 volts. 4. Yeah. Actually, we need the adapter cable here so that we can see local electrical.
Yep.
Okay? G-Rod, please connect the adapter back into this quickly. Just do a quick switcheroo. We'll have some non-captured beats. It's okay. Please. There we go. Real life, right guys? Okay. So now base at 5 volts, so we can see our local electrograms and we'll be able to see if it pushes out. So 3 volts. Come down to 2. Now come down slowly. Can you guys clip the unfiltered signal, please? Clip the unfiltered signal.
So what was the threshold there?
1.1.
1.1.
Okay, let's check bipolar real quick before
Yep.
we run out of time.
And before you do that, Parikh, show us the unipolar electrogram on the analyzer and the PSA.
Yes, can you switch to PSA screen, please?
So unpaced electrogram from the is it not connected to the electrogram?
You have the including GM, right? JR?
Okay, so that's the one. So this is important. So let's say if the pacing threshold was 2 volts, and as long as you have injury current on the electrogram, that's a good sign. It will come down. But if you have fractionated electrogram, then it's a sign that you've perforated. So that's good. The impedance is good. Injury current is good.
I think this will get better. I'm quickly going to check bipolar
Yep.
on there.
And we can see if there is anodal capture or not.
Yep, so there is bipolar connection. Let's start at 5 volts, please. 8.7 is our operating.
Yeah, there is anodal capture.
Anodal capture.
So the R waves become smaller. The QRS is even narrower.
Basically, come down to 3 volts.
It's still there. Yeah.
Now come down there.
Yep, there's. That's your anodal capture threshold. So
So we're transitioning from anodal capture to what seems like possibly non-selective left bundle capture at 2 volts. Can you go to the sweet speed of 150, please, so we can appreciate a jump off, please, on line? 150, good. Keep coming down.
you have 40 seconds, and you've done an excellent job, Parikh, and perseverance. There's selective capture.
There's a separation in the local EGM suggesting
And then that's selective capture. So we won't see a potential in this electrogram because he has left bundle branch block. So this is very nice demonstration of anodal capture, non-selective left bundle capture, and selective left bundle capture. Fantastic job, and thank you for the team and for a good job well done. Don't know if we have time for questions. We can. Any questions from the audience and the panel?
It's time's up, huh?
Yeah, but if you have questions, anything, so just make a comment.
I think that's just an example of a real live case. Sometimes it's not straightforward, sometimes it's tricky. And I think it also shows the limitations of the equipment we've got at the moment. So I think in time to come we get more tools. I think that'll make it easier. And also to understand the nuances of what you're seeing. It's just not a mechanical procedure like putting in an LV lead. So there's a lot of nuances you've got to pick up on to make the case successful, but I think they did a great job.
And I see quite a few engineers in here, so we know what the limitations are. The next time we see, you'll have better tools for us. Thank you very much, and thank you for the audience for staying patient. And let's give one last.
This is the panel member that turned up.